Good day, everyone. I am Dr. Ping Chan from the University of Hong Kong. It's a pleasure to present our review on the role of telemedicine in joint replacement surgery, an updated review. As technology intersects with surgical care, joint replacement surgery has experienced significant transformations. The rise of telemedicine presents new opportunities to enhance patient care and optimize outcomes while addressing long-standing challenges. In our review, we conducted an extensive search of medical literature using reputable databases such as PubMed, Medline, Embase, and Cochrane. We focused exclusively on English publications from peer-reviewed journals to ensure the highest quality of evidence. Current tele-rehabilitation technologies in total joint arthroplasty include motion tracking cameras, visual cameras, and applications that provide personalized exercise regimens along with real-time feedback. Notably, the virtual exercise rehabilitation assistant has shown promising results for patients undergoing total knee arthroplasty and unicompartmental knee arthroplasty. Additionally, remote coaching enhances resource utilization and patient satisfaction, although web-based materials may not be suitable for everyone. While evidence for tele-prehabilitation remains limited, some studies indicate benefits such as shorter hospital stays. The effectiveness of these interventions is largely dependent on the design of the protocol and the dynamics between patients and therapists. Our experience during the COVID-19 pandemic was positive, but it also highlighted gaps in patient knowledge and technology use. Now, let's take a closer look at our local experience with tele-rehabilitation during the COVID-19 pandemic. We utilized the HAGO application system for tele-rehabilitation, which provided features like video-based physiotherapy training, allowing patients to conveniently access rehabilitation exercises. Here, you can see the attention notice along with visual and text instructions for each exercise, including the number of repetitions and sets. These elements were designed to effectively guide patients through their rehabilitation journeys. Now, let me direct your attention to this table, which summarizes the results of our local program involving 21 patients with knee osteoarthritis. Before the telerehabilitation program, 52% of patients reported moderate or greater difficulties going upstairs. This figure decreased to 33% post-program. For difficulties going downstairs, the percentage dropped from 76% to 57%. Walking tolerance improved from an average of 35 minutes to 40.24 minutes. The EQ5D3L index, which measures quality of life, increased from 0.74 to 0.81. Notably, patients' knowledge about their condition also significantly improved. In terms of pain, the numerical pain rating scale showed significant enhancements both at rest and during movement. Overall, our local experience demonstrated the feasibility and positive impact of telerehabilitation, although there are still areas for improvement. In conclusion, telemedicine holds great potential for prehabilitation in TJA, with various platforms offering unique advantages and challenges. I would also like to draw your attention to the special issue on healthcare transformation in joint arthroplasty, which I co-edited with Dr. Nicholas D. Clement. This issue features 6 insightful papers covering critical topics such as the pandemic's impact, day case arthroplasty, and the role of digital health. Our review is part of this valuable collection published in Arthroplasty. Thank you for your attention.